Thank you very much. Good morning, everybody. It's always a privilege to be the first one with a lot of people to ask many questions, which is a very great privilege. So how to assess the microcirculation? So to understand how you can assess the microcirculation, we have to admit that the pivotal role of the cardiovascular system is to supply the tissues with the substrates of metabolism and get rid of the waste products of metabolism. So that's the pivotal role of the circulation of the cardiovascular system. Whether it's the macro hemodynamics or micro hemodynamics, this is the basic function of the circulation. Without perfusion, you are not going to have any other functions at the tissue level or at the microvascular or the macrovascular level. So perfusion is actually the key word to understand how to assess the microcirculation. So it's about perfusion. And the main substrate is oxygen. We need it every time. We can't save a lot of oxygen at the tissue level because it's very toxic. So we need a continuous supply of oxygen. We need it. So to assess the microcirculation, you have to assess the perfusion of the microcirculation in terms of quantity maybe, or also the quality of this perfusion, which is the assessment of the oxygenation. So the assessment of the microcirculation implies two main principles: the assessment of perfusion and the assessment of oxygen availability. You can add to this some specific functions of the microcirculation to assess the microvascular functions. So to assess the microvascular perfusion, you can use some sort of a direct devices to look at the microcirculation to see the blood vessels at this level and try to see if these vessels are perfused or not. Or you can indirectly look at this perfusion. So if the perfusion is functioning appropriately, the metabolism is okay, waste products are eliminated. But if the perfusion is impaired, there will be some sort of accumulation of these waste products at the tissue level. So indirect assessment implies looking at the indices, for example, of disturbances in oxygen utilization, like lactate pyruvate ratio, and also at an important metabolite, which is the carbon dioxide. So you can use regional capnometry to assess indirectly the perfusion at the microvascular level, or you can also use some sensors to look at the carbon dioxide or the pH. You can use also the indices of oxygen delivery, oxygen utilization mismatch, like the central venous oxygen saturation and the mixed venous oxygen saturation. So that's the way to look at the perfusion, directly and indirectly. Assessment of oxygen availability will be discussed in details in the next lecture, so I'm not going to elaborate too much on this. But you can look at the oxygen availability using some electrodes, optode sensors, using some optical properties, using some spectrometry. And at the end, you can look at the microvascular function using occlusion plethysmography or to look at the occlusion reperfusion characteristics using certain devices, and I'm sure also that the next lecture is going to talk much about this. So what can we see? How to visualize the microcirculation? How to visualize the perfusion at the microvascular level? Do we have some devices to do this? Well, in the last years, a lot of technology have appeared to be incorporated in some sort of handheld devices to visualize the microcirculation. So you can incorporate these devices to look at the blood vessels at the microvascular levels. You can also see some erythrocytes, leukocytes. You can look at the blood flow directly using your eyes. You can measure some capillary density, microvascular perfusion diameters, and maybe velocity if you are using some new softwares. So these methods started more than 20 years ago by Neil Fold capillaroscopy, a very small microscope that you can apply to the nail fold bed. At that time, it was not very small, so this method didn't attain a lot of popularity, in addition to the fact that it's looking only at the nail bed. Other devices became smaller. These handheld devices, starting with the OPS technology, passing through the SDF, and we have also some newer generations of these microscopes. The idea is very simple, and whatever the technology that is used, it's actually trying to make some sort of a sharp image of the microcirculation at different levels. Using these devices, you can look at mucosal surfaces. You can put it under the tongue, so you can see the sublingual microcirculation. I'm sure that you have seen a lot of images like this in a lot of sessions before. But the main idea is that to look at the microcirculation directly at the mucosal levels or even under the skin. You can use also these devices to look at the capillary bed under the nails also if you want. You can look at stomas, you can look at the rectal microcirculation if you want, but you have to have an accessible site in your patients to be able to look at. So these devices are limited a little bit by the fact that it's not able to look at the microcirculation all over the body. But nevertheless, a lot of studies, experimental and clinical studies, have shown that these devices are able to detect microvascular alterations in several disease states. Like sepsis, for example, this landmark paper by Daniel De Becker, showing that microvascular alterations exist. You can look at it under the tongue. In the septic patients, you can see that septic patients who die more have more alterations in their sublingual microcirculation. We were able also to show this in this paper, looking at the time course of microvascular alteration over time, and we were able also to show that the persistent microvascular alterations are related to poor outcome in patients with sepsis. Not only looking at the pathophysiology of the microcirculation, but also at the therapeutic implications of some therapies. Here we were able also to look at the effect of blood cell transfusion on the microcirculation, showing that some patients may get benefit of blood transfusions if they have an impaired microvascular perfusion from the start prior to blood transfusion. You can track also resuscitation during sepsis, during using inotropic drugs or vasopressors. In this study, you can see that the administration of dobutamine improves microvascular circulation in patients with sepsis. But these techniques are a little bit limited by the fact that most of the possible analysis of images is based on semi-quantitative methods. We have some new softwares that look quantitatively at the perfusion, but to obtain images to be analyzed is very difficult. They are liable to pressure artifacts. They are actually also liable to a lot of artifacts related to the fact that patients are moving their tongue most of the time if they are not mechanically ventilated and sedated. If you have a lot of saliva in the mouth, it will be difficult to get some sharp images of these patients. So the analysis of the images obtained by these devices is rather challenging. There are some methods to analyze these images semi-quantitatively, like the method that we were using in Brussels a long time ago. Just draw some lines on the images, you just look at it, you just count the number of vessels crossing every line and whether they are perfused or not. Or you can use a very easy method to make 4 quadrants and look in every quadrant and try to score the microvascular perfusion in these quadrants and give a microvascular flow index. But again, all these methods are more or less semi-quantitative. And the question is to see or not to see. The microcirculation is not that easy. You may see that the perfusion is good, but it's not going to the right place. It's not going to the right cells. And the microvascular perfusion is also very heterogeneous. A phenomenon that occurs in some patients with sepsis is microvascular shunting, for example, which implies perfusion which bypasses the tissues. So you can see that the tissues are perfused. You can see that the vessels that you are looking at are perfused, and by the end, it's perfused actually in the wrong direction. So it's bypassing the tissues. Looking at the perfusion indirectly or measuring it using some properties of light or laser lights are also in the market. You can look at microvascular perfusion using this technique of laser Doppler flowmetry, which is based on the duplex effect. It's very easy. You can have a very small electrode or a very small device that looks at the oxygen carrier, which is the hemoglobin, and you can measure the flow of, or the influx of red blood cells moving within a blood vessel. So you can measure more or less the relative blood cell velocity. If blood cells are there, you can detect them and you can say, okay, the perfusion is good. But again, this is very challenging. Where to put this electrode, that's a big question. You can incorporate it in some electrodes, you put it in the skin, you can even put it on the sublingual area, or you can also incorporate it in some nasogastric tubes to put it to the gastric mucosa. But again, some artifacts may be produced using these devices. And the fact that you are looking at a very small capture area and you are not looking at the direction of the flow means that sometimes you may miss the microvascular alterations because some areas are well perfused and other areas are not well perfused, and you are measuring the average flow in an area. So if it's normal, it doesn't mean the microvascular alterations are not there. It just only means that you didn't account for heterogeneity when you look at the microcirculation using these devices. So the indirect methods to assess the perfusion implies, as I told you before, looking at the metabolites of the cells. If the perfusion is good, the metabolites are not going to accumulate. If the perfusion is bad, you have some sort of accumulation of metabolites. That's exactly the idea that we use to develop such devices like gastric tonometry. So tissue hypoperfusion will lead to tissue hypoxia. Tissue hypoxia will lead to tissue hypercarbia. So carbon dioxide is a very important metabolite that you can look at. This was incorporated in the gastric tonometry. You just insert a balloon using a nasogastric tube in the stomach, and you use this balloon to measure carbon dioxide at the mucosal level. The old gastric tonometry devices imply saline tonometry, putting some fluids in this balloon and trying to create some equilibrium between the fluids in the balloon and the mucosal surfaces. And you then get this fluid and analyze it using a blood gas analyzer. Newer devices have implied doing this using air tonometry, which means that you don't put fluids, but you put some sort of gas, and you recruit it again to measure the carbon dioxide in it. But again, these methods have been used largely in experimental studies and in some clinical studies, but they didn't gain a lot of popularity. You can see here in this experimental study, for example, that you can track the changes over hemorrhagic shock and sepsis in terms of changes in the microvascular perfusion and the effect of resuscitation thereafter. But again, these methods are limited by the fact that they are semi-invasive. Let's say a lot of interference with feeding, with acid-blocking medications. Well, that's a limitation of the older generations of the gastric tonometry, but nevertheless, you need some time to analyze what you get out of these data, and the cutoff points and the clinical utility are not very sure. That's why we are not seeing these methods at the bedside, despite the fact that we had them in the market since more than 20 or 30 years. So the question, I have 2 minutes, yes. The sublingual capillometry is actually an extension of the concept of tonometry, which implies looking at the proximal gastrointestinal tract, looking at the same thing, but using a probe that you put it under the tongue and you measure the carbon dioxide using these probes. Some studies have shown that it works very perfectly in detecting and tracking microvascular alteration during resuscitation of sepsis. Again, you can look at the global view of your oxygen utilization and oxygen delivery. So if oxygen utilized properly at the tissue level, you are going to have some oxygen at the venous side, which is actually the reserves that you need to compensate when you have a problem. If you don't, like for example, when you have some sort of microvascular alterations and problem with the metabolism, what comes back in the backstream is very little oxygen because you are using your reserves, which means that you are going to have less central venous oxygen saturation and mixed venous oxygen saturation. And that's exactly the idea of using the central venous and mixed venous oxygen saturation. I concentrated on the first part of the lecture, and I'm going to skip the oxygenation. I'm finished already. Yes, I have 30 seconds or 10 seconds. So I skipped this deliberately because the next speaker is going to talk about this. And the last thing, as I told you, is looking at the function using such curves. You do occlusion and reperfusion. If the microvascular function is impaired, you have an impairment of this sort of curves that you obtain looking at the microvascular perfusion with the laser Doppler or with the methods that are used for the detection of oxygen at the tissue level. So I'm finished.
Thank you very much.